Welcome everyone. I'm Dr.Supakij Khomvilai from Surgical Endoscopy, Chulalongkorn Hospital, Bangkok, Thailand. Today I'm going to talk about image-enhanced endoscopy for colorectal lesions. This is my hospital in the center of Bangkok, capital of Thailand. I'm a colorectal surgeon and my main work is colonoscopy. I take care of our surgical endoscopy center. With the current knowledge, colorectal cancer are originated from colorectal polyps in either pathways. This made us as endoscopists can prevent colorectal cancer by finding the polyp and cut it out to prevent cancer. NCCN guideline this year, they reduced the age of average risk to get screening to be 45 years old, and colonoscopy is the best choice because we can do treatment at the same time. The key of success for screening colorectal cancer is to find out colonic polyp and cut it out to prevent cancer. These are tubular adenoma which was confirmed by NBI using the characteristics of superficial vasculature and surface structure. All of them should be removed when we found during colonoscopy. Current technology of colonoscopy, we can find this small adenoma as I showed you on the right side and cut it out to prevent cancer. In some institutions, they do not cut small adenoma and choose to syringe after small adenoma was detected. But in my endoscopy center, I prefer to cut off of adenoma I found because our patient will not come back for syringe and it might have the problem later. Colonoscopy can detect lesions that need to be removed, and we need to characterize them to choose appropriate treatment for each lesion we found. With the power of image-enhanced endoscopy, we can get better detection as I showed you earlier. Not only detection, we can get accurate characterization and safer during the treatment. This is another example of new generation of high-definition colonoscopy. Make endoscopists can detect the small lesion like in this picture. Can you see the lesion? This is the lesion we found from our daily colonoscopy. Because of high-definition image can make better contrast of normal mucosa and polyp, so we can detect more lesions from new generation of colonoscopy. And magnifying colonoscopy can get closer look at suspected area. When applied the NBI, endoscopists can see the difference of mucosal surface and vascular structure. Then the diagnosis can be made with confidence. And these cystite-related lesions have potentially turned to be cancer, which is difficult to diagnose by conventional white light. But with NBI technology, endoscopists can differentiate these lesions from normal mucosa. The problem when we found the polyps, non-neoplastic can left inside. Neoplastic polyp should be removed, but malignant polyp should be removed adequate as oncologic resection. So endoscopic diagnosis is very important and crucial. And these are important to remember. Carcinomatous area should never be cut into pieces. How about this lesion? Do we need surgery for this lesion? Actually, all of these lesions can be resected by endoscopy with adequate oncologic resection. But we need to get accurate preoperative diagnosis by using image-enhanced endoscopy. The standard treatment for invasive colorectal cancer are surgery to remove tumor and lymphatic, also vascular supply to achieve oncologic resection. And these are the results after surgery. Either laparoscopic approach or open surgery, we need surgical wound to enter abdominal cavity, and sometimes colostomy was created. Complication after the surgery, roughly 20%, even with the laparoscopic approach, are the same. But these are just immediate complications after surgery. They have more complications later, such as gut obstruction from adhesion and complications related to colostomy. Compared to endoscopic resection, this patient underwent ESD for ascending colon lesion, and this is postoperative day 1. He can enjoy walking around the hospital and go back home in a few days. Endoscopy is better for the patient. compared to the surgery. So the question is, can we do the endoscopic treatment for malignant lesion? Because malignant lesion should be resected as oncologic resection. And how could we know that these malignant polyps have lymph node metastasis or not? Bigger size have more chance to be cancer, but it's not always true. T1 colorectal cancer have chance for lymph node metastasis 7 to 13%. And these are risk factors for nodal metastasis: depth of tumor invasion, poorly differentiation, lymphovascular invasion, the budding, and location at the lower rectum. From our own data in surgical endoscopy, Chulalongkorn Hospital, we found lymph node metastasis is 10% in T1 colorectal cancer. From this data, 9 of 10 patients do not need surgery to remove lymph node. Only endoscopic resection as local treatment is adequate for oncologic resection. In Japan, malignant polyps are classified by depth of cancer invasion as intramucosal cancer, superficial submucosal cancer, and deep submucosal cancer. The cutoff level of tumor invasion is 1000 micron from muscularis mucosa, and if the cancer invades beyond this point, it has a chance to go to the lymph node as a lymph node metastasis. For superficial submucosal cancer without lymphovascular invasion or poorly differentiation, they have very low risk to metastasis to the lymph node, so we can say that it's no lymph node metastasis. And we can divide the malignant polyp to be early colorectal cancer, which is the intramucosal cancer, and superficial submucosal cancer, and invasive cancer, which have chance to be lymph node metastasis and need surgery to remove the lymph node. But for the early colorectal cancer, we can do endoscopic treatment as local treatment, and it is adequate as oncologic resection. So we will focus in early cancer, which we can do endoscopic treatment. Endoscopists can use the in vivo differentiation lesion we found by using the NBI or narrowband imaging as image-enhanced endoscopy. NBI is optical filter technology, which can change wavelength from the white light to blue and green, which hemoglobin can be absorbed, and we can see superficial vascular pattern and surface structure. We use nice classification to classify polyp and design proper treatment. Nice classification, we look at the color, vascular pattern, and surface pattern of the polyp. These are examples of nice classification in our patients. In some cases, we need more detailed observation by magnified colonoscopy. Genetic classification are essential to differentiate malignant polyps. The most important is Genet 2B lesion, which consists some of the invasive cancer. So in this illustration, show how we made diagnosis by using IEE to design proper treatment for lesion we found in colonoscopy. Basically, I'm using the NBI as a IEE to differentiate lesion, sometimes with the indigo carmine, but we don't have the crystal violet in our country, so most of the time I use the NBI. An advanced technology. With the advanced technology, the advanced therapeutic endoscopy like ESD can done successfully when we have accurate preoperative diagnosis of the lesion. And these are the specimens we done successfully ESD procedure. Today I have two cases to show you that how IEE help us to diagnose the lesion and then give the accurate diagnosis before the treatment. What is your diagnosis for this lesion? Tubular adenoma, side-related lesion, intramucosal cancer, or the malignant invasive cancer. This lesion have depressed area in the center of the lesion, which we have to be careful to take a look closer in the detail of surface and vascular pattern. From NBI, it shows nice type 2 and Genet 2B character in the central area. They have irregular surface configuration in depressed area, but not definitive invasive-like pattern. My diagnosis is early cancer or non-invasive malignant polyp. Possible diagnosis is intramucosal cancer. When we have diagnosis of malignant lesion, we have to keep in mind that the lesion should resect en bloc as one piece. Like in this lesion, I choose EMR to remove malignant lesion with normal margin to achieve complete resection, like this. And I always close the resected area by endoscopic clip to prevent delayed bleeding. The pathologic result come back as intramucosal cancer without lymphovascular invasion. This is another case. What is your diagnosis? Tubular adenoma, side-serrated lesion, intramucosal cancer, or traditional serrated adenoma? The correct diagnosis is traditional serrated adenoma. I will show you the detail of observation by NBI as an IEE in the video. In white light, the lesion have protruded area and look like to have extended part at the base of the lesion. Like this. When switch on the NBI, it shows a better view of the margin, which extend laterally at the base of protruded area. Like here, you see closer. With near focus magnification image, we can observe two patterns at the same time. On the flat elevated area is the nice type 1, but protruded area, this is the nice type 1. On the protruded area is showing nice type 2 pattern, which made my diagnosis is traditional serrated adenoma. And in this case, I choose to do the hybrid ESD to remove the lesion to get adequate margin. After the injection of the saline plus the indigo come in, I start circumferential mucosal resection by using the dual knife to make sure that you get the negative margin. And keep dissecting into submucosal layer. Then move to cut at the back side of the lesion to complete the circumferential cutting. Then press the snare to cut the whole lesion. And close by endoscopic clip. Pathologic study report traditional serrated adenoma. In this lesion, NBI as an IEE help us to achieve adequate polyp resection. If you cannot make definitive treatment for lesions you found, please do not biopsy or tattoo because it will have fibrosis. And sometimes it's very difficult to do EMR or ESD later. Only take a lot of the photos is enough for referral center to have information of lesion you found. This year, new generation of endoscopic system are released from the Olympus X1, which have this new feature of IEE to elevating standard of endoscopy. TXI for better detection, brighter and sharper NBI for characterization, RDI for safer therapeutic procedure. This is the example of TXI or texture and color enhancement image, which designed for delineate margin of lesion as I show you in this picture, especially the flat lesion like this. You will see the edge of the lesion without any dye applied to the lesion. Just switch on this TXI image, you will see it. And this is the picture of the white light of the polyps. With the new generation of the endoscopy, you can see the better, sharper of the image. So because the picture now is the 4K, so the image was sharper than previous generation. And with the bright and sharper NBI, so you can see the detail was very clear, and this is night type 2 of the lesion. And for the sessile-serrated lesion like this, I compare the previous generation CV190 on the left side and then the Olympus X1 on the right side. And on the right side, you can see the typical open pit type 2 is very sharp and clear. And you can give the diagnosis of sessile-serrated lesion with confidence on the NBI, like in this picture. With the RDI or the red dichromatic image, you can see bleeding point easily, then you can apply the coagulation directly to the bleeding point. When you apply the RDI, the color was changed to yellow, and you can show it shows you the bleeding point that you can stop by using the coagulation forceps. And you may not get nervous of the bleeding because the color is yellow. I made a video clip in my YouTube channel to introduction of Olympus new endoscopy system Olympus X1 within 8 minutes. So please scan QR code to watch the detail of how good this new system helps you to elevating the standard of your daily endoscopy practice. Endocytoscopy are available for more additional information to make more accurate diagnosis. In conclusion, the power of image-enhanced endoscopy, IEE, we can get better detection to find existing polyp, accurate characterization by detailed observation of colorectal polyps, then removed by proper and safer procedure including oncologic resection for early colorectal cancer. New generation of high-definition colonoscopy and chromoendoscopy are available and essential for daily colonoscopy. If there are any parts of the lesion was suspected cancer, it should be resected by en bloc resection. Endoscopy is not one-man show work. Your team are very important for the success. So good luck and take care.